Good morning. How are you today? I feel great. My name is George Johnson. I'm your facilitator for today. And I'd like to welcome you all and also want to give a note of appreciation to the Sanford Burnham Medical Research Institute. They provide this facility, and I'm sure you'll keep it clean and neat. And if you need other facilities, they're out the back door and down the hallway. May seem like a quarter of a mile if you're in a hurry, but it's down there. And we have a special double feature program today, which I'll describe in a minute. But first, I want to make you familiar with the guys that make this thing work. And there's over 85 years of prostate cancer experience amongst these volunteers. They're not well paid, but the benefit program is wonderful. We get a lot of joy out of being able to serve you and others in their needs. Lyle's here today. Raise your hand, Lyle. Is the only one with a hat on, so that's how you know the captain of this ship, our leader, and our stimulus for doing a good job. And the guy that makes things run is Gene Van Vliet, right here. And you'll be hearing from him in the introduction. I'm your facilitator, and then Bill Manning, back there in the dark section, but by the red light. He's the videographer and also a director of our operation. John, where are you, John? There he is, way in the back over there, and John is also a director and the webmaster. And we encourage you to check out the web frequently. And then Big Bob here, there he is, our librarian, and he's also helped by Bill to offer books. And this is a special event that we have here for this support group. And then where's our welcomer? Jim? Jim's the guy out there with the smile. And so he wants to make sure you have a yellow sheet to fill out if you're a newcomer. If you'd like to volunteer, you're welcome, and talk to Gene about what you might be able to do to help us. What are we? We have a newcomer package. Every newcomer get a yellow package. Okay, there's one there. Didn't get one. We'd like you to fill that out and the cover, and then keep the packet, because that's we have designed that to give you a little background and a primer on prostate cancer and some of the lexicon that's used and so forth. I think you'll find that helpful. Now, one of the elements of that yellow sheet is for you to put your phone number down so Gene can give you a call and welcome you and answer any questions you might have. And that will occur next week. Okay, what is this support group about? It's to support you and to help you become your own case manager. I have a good doctor. He has 10 minutes for me. And one of the guidance is, because time is short for him, because he has thousands of patients, get prepared. List your questions that you have. Bring your questions in there. Write down the answers. Keep a copy of every lab report. You're the one that has to determine when you think you need a PSA. Remind him. So some of these things you have to run, and you can't fully depend upon them to have a schedule and be thoughtful of you all the time. So that's one of the things we try to help you on guidance. But we're not a substitute for your doctor. We may suggest some questions you might ask them, but we're not here to recommend any treatment or any suggestion of that nature. Okay, what do we need to be able to support you? Well, we need some money. We need some donations. We're a 501c3, so you can deduct taxes for that. And we're not affiliated with any religious or medical organization. So here's an opportunity to increase your tax deductions, okay? Let's pass the baskets, and we're looking for because these are small baskets, we're looking for big bills, okay? Bills with a zero on it are helpful. If you want to do a double zero, that's wonderful. But a single zero is what we think is be appropriate. And it's sort of like what you pay for a movie. And today's a double feature, so think about that. So let's get those baskets going down the aisle. Dig deep. And okay.
Can we donate online?
Yes. Okay, what do we do with the money? We spend it on you, and here are some of the things. We have a wonderful website. It's the video on there from nationally known prostate cancer experts. Dr. Myers, known as Snuffy, has a different subject every week, so you want to check it frequently because it's very informative. We have a special library here of DVDs and books. Some you can are free, some you can rent, and more importantly, some you can buy, and that money is used to help finance this operation. We have a wonderful newsletter where it's out of supply out there. Here's what it is. Get on the website and click on newsletter, and it's got a lot of good stuff on there about our forthcoming meetings. Even have a few cartoons that lighten your life. Gene is our editor and does a super job on that. Spends a good amount of time on doing that. Okay, outreach. The key thing that's important is why are you here today? Because you heard about us, somebody suggested, and so forth. So we have an outreach program. And a key thing in the outreach is get a PSA test. Get a PSA test because that's important for early detection. If you don't want early detection, don't get a PSA test, okay? It may be too late because, as you guys know, the symptoms are not necessarily readily apparent. By the time you have apparent indications, it may be too late. So early detection is the best approach here. And so we have outreach for new members. We have brochures. We have business cards. Grab a few of these and share them with your friends out there and encourage them to come into the program because I think they will find it as helpful as you do. Okay, we have monthly meetings. We're going to have a meeting next month. We're going to keep it a secret and surprise you with results. Let me do now the survey of our group.
George, may I interrupt?
Yes.
I have a library problem here. I had 6 CDs here covering the China study. It was here when the meeting started, and one of them is missing. If somebody took it off the table, please return
I have the answer to that.
Oh,
It was not taken. Someone brought that deck in last meeting and said he's had it for a long time. He didn't know where the 5th one was. And had me search to see if I had it in the master library. We have no idea where it is. So there is no 5th one.
but it was here.
Probably
I personally saw it.
5 years ago.
I saw it just this morning.
Deal with it up.
Yes.
The mystery continues. Come back next month and we'll have an answer for you. Okay, I'd like you to raise your hand if you're here for the first time. Get those hands up. Look at that. We got some newcomers here. I want you to know you're welcome. And I think you'll find this of value. If not, come tell us what you're interested in and we can maybe adjust the program for you. Okay, how many have just been recently diagnosed in the last 6 months? Okay, so you have a need to be informed about the program and you're at the right place. How many have had prostate cancer for up to 1 year? Okay. Next, how many up to 4 years? We're building a bell-shaped curve here. How many of 5 to 10 years, survivors or double survivors? About an equal number. And then 11 to 15 years. Okay, now the bell-shaped curve is coming down here. How many have more than 15 years? I got 17 now. Okay, and then anybody beat Bob? What do you got, Bob, now?
22.
22 years. It works. If you're working over here?
25.
25. Oh, a grand award. You get a special award. come back next week. No, next month. Okay, that's a good profile. And now let's do a check on the treatment. Raise your hand. Now, if you've had, some of you, like John and Jean and me, have had a number of opportunities to try different treatments. So every time I mention one, raise your hand. Now, first is active surveillance, and we're not just talking about watchful waiting. We're talking about active surveillance. How many have used that as their first treatment? Raise your hand.
Good.
That's fantastic. By the way, recent studies have shown those that are on active surveillance don't have a relapse or a more serious turnout. Up to 98% of those are on active surveillance. So it's a system and approach, medical approach that works. And it's growing in use, and urologists are now starting to recommend that as the first step. Okay, normally what they tend to recommend is surgery. How many have had surgery of the prostate of some kind? Wow, that seems to be the standard here. Let's check out the next one is radiation. How many have had radiation? About an equal number, and some of you have had both. Okay, now how many are on ADT, or what we call hormone therapy? I'm on that too, and let's see, we're doing a one-third, one-third, one-third here. How many are on chemotherapy? Okay, we have some good news on chemotherapy here, and there's a few here who are still coming back. That's good. How many are doing some of the new treatments like Provenge and HIFU and cryo? How many? Not that many. Yeah, that's not a big content. And Gene's has had Provenge, and it's working for him.
And now Zofigo.
It's Zytiga.
Zofigo.
Zofigo. Don't ask me where they create these names. Okay, recurrence. How many have had a treatment and then it came back? That's me, and that's about a fourth of you are going through that. And how many are looking at a treatment and not fully decided what they're going to have? Hopefully this program here will help you make that decision. And talk to your neighbors about this and get their experience. And that's the purpose of today, is to get the experience from some of our attendees. Now, normally I bring up an element of case management, and I have a personal experience I'd like to share with you. I'm a king of side effects. I get every side effect. I get constipation and diarrhea at the same time. I mean, I get every one, hot flashes and things. So I got a new one. I didn't realize it was a side effect for prostate cancer treatment. Shingles. Oh. Yeah, I got shingles. And the Mayo Clinic died.
I'll bring you to life.
I've studied this. My doctor said, oh, this is the shingles season. I'm the third person this week that she's seen with shingles. So get a shingles shot. The profile of shingles is it occurs in older people. I'm upper middle age, and so I'm in that zone, and I think many of you are also. So get that shingles shot. It's not permanent. It's not like smallpox. It has a life. It has a life of maybe 10 years or so. So ask your doctor about getting another one if it's been some while. And normally you don't, once you got it, you don't get it back. I've had it 5 times. And the reason, according to the Mayo Clinic, is I got the profile for that. I'm having cancer treatment, which tends to be a little bit disruptive to your immune system. So the other thing is radiation kind of affects your immune system. So get a shingles shot. That's a good idea, and you avoid the pain. Okay. Here's today's agenda. The double feature is we're going to have a panel of treatment experts, and then we're going to have a network breakout section. And here's what that looks like. we'll break out into different quadrants of this room. And, but first, let's go back to our opening part with,
He's in the complex over there.
you've already heard from Gene. There he is, my boss and the guy that really makes this thing run.
Okay, here we go. We will have one more guy here. He's lost. Sometimes it's too obvious. There's a complex of buildings for Sanford Burnham down there, and they think automatically you should turn in there. And once you get in there, you can't come out, in case you didn't know. Okay. Just a couple of things. George mentioned it briefly. I just want to reinforce that all of you have a responsibility now for outreach. Since the Federal Commission decided that it was no longer useful, beneficial, too costly to do PSA testing, that doctors won't automatically do it anymore. The net result, as George mentioned, is Dr. Lamb verified it, 2 other urologists that I've talked to have verified. What they're seeing now is people coming in with more serious cases of prostate cancer because they're not catching it soon enough. So you are our outreach people to help. Tell your friends and neighbors that they need to ask for a PSA and a digital rectal exam to determine if you have it yet. Because, as he said, you don't feel it till it's too late, usually. So, just like to keep reinforcing that. I want to mention a couple of books that's always worth mentioning in this group. One is the Invasion of the Prostate Snatchers. Do you still have some, Bob? Invasion of the Prostate Snatchers. You still have plenty?
Yes.
Okay. It's written by Dr. Mark Schultz, who's with a prostate oncology specialist up in the Marina del Rey, who are doctors to many of us here. It's a very good primer, especially for newly diagnosed, to learn about our disease. It's Invasion of the Prostate Snatchers. It's kind of tongue-in-cheek title. He's not saying you shouldn't do surgery. He's just saying that you should do a lot of research and find out a lot about your disease before you make any decision. Another one that's really doing well for us now is the Prostate Cancer Breakthroughs 2014 by Dr. Jay Cohen. He mentioned our group and me and our phone number in the book, and I'm getting calls from all over the nation, and even had one that's Lyle remembers from Pakistan. So it's, our group is becoming very well known now. So I think we'll just jump right in then to have some of the guys talk about their experience, because we are the experts in dealing with our disease, really. We've been through it. A lot of us have been through a lot. And so, David, will you jump in first?
Sure.
Meantime, I'll replace you with a better.
Okay. Hi.
Roam around as you wish.
I'm getting in that point in life where I can't remember a damn thing. So I've written down all the key words here that I may need to refer to now and then. I can't remember ever asking for a PSA test. So when I was turning about 50, I think my doctor said, it's time for a PSA test. And I had one, and I think I had a PSA, it would have been, I was about 55 at the time, before I ever had one that was worrisome, and it was about 4. That was in 1997. I had then a biopsy. The biopsy showed a lot of something they call PIN, which is sort of a pre-cancerous condition. They didn't explain it to me. They just said, "Nah, you don't have cancer. Go away." So I went away, and a couple years later, I had a PSA maybe around 6, and so I had another round of biopsies then. Those biopsies were also negative except for PIN, but I should have been probably doing a biopsy every 3 months or something, because when I went back 2 years later, with a PSA of about 8, I had 8 of 10 samples had cancer in them. So when I got notified of that, you have to watch out about terminology, because the doctor who did the biopsy called me and said, well, you have positive results. Well, positive results in a biopsy is not good. And he said, so you do have cancer, he did say that, and you now need to decide what you want to do. He gave me absolutely no suggestions. He didn't immediately say you need surgery, but as I investigated the various options, I said, why would I want to get radiation when radiation causes cancer? You know, that was probably a silly decision, but I decided I really liked the idea of getting that prostate out. I was a little concerned about the side effects, incontinence, loss of erectile capability, but I was also interested in staying alive for longer, so I said, yeah, let's get that out of there. So in 2001, I had a prostatectomy. When they looked at the prostate afterwards, I had 9 separate cancers in the prostate. 3 of them were microscopic in size. There were 6 others that were not microscopic. One of them had gone up into the seminal vesicles. I was very grateful that I had had the surgery, because that means it's out of the actual prostate and was starting to invade the rest of the body. I had a friend about the same time who avoided getting a PSA until he was like 65. When he got his PSA test, it was in the 60s or 70s. Went in to get surgery, and they opened him up and said, no, it's everywhere. Can't do anything for you except androgen deprivation, which they did. And so we talked about our problems. I couldn't get an erection. I had lots of sexual interest, but no erectile capability. He had erections all the time, but had no sexual interest. So we said, is there some way we can combine forces? But it didn't work. So I was working at Walter Reed Hospital in the District of Columbia at the time, and they had a program there of immunotherapy where I could take something, because one of my cancers had something called HER2, which apparently is very common in breast cancer. And they had quite a successful program with breast cancer. So I tried this. I said, how do you know if it works? They say, well, we only know statistically. So we'll keep track of the whole cohort, and maybe we'll find out that some of you live longer that were getting this than others that don't get it. But when they looked at my, they said I had a good possibility of lymphatic invasion when I had my, what they call it, the pathology report. And I ignored that part because I had clean margins. I said, oh, good, it's nowhere else. And yet, 6 years later, my PSA started rising. It's been rising very slowly. It went from, I think it started at 0.04. It's now at 0.8 or 0.9, getting up to the 1 to 2 range, where I thought, oh, good, I can go get the one of those tests, the C11 choline or C11 acetate. They can show me exactly where my prostate cancer is, and I can get it treated. Well, I went to this conference. Where did I put that? I don't know if you are all aware of this prostate cancer conference. It's in LA. It's a wonderful conference, and you get to know about all of the new treatments. I was waiting for my PSA to get up to being 1 and 2 so I could get one of these new tests. Well, once my PSA got up close to 1, I talked to the guy who does the test, and he says, yeah, well, yours is too slow growing. We're probably not going to be able to see it in those tests. So now I'm looking at, you know, when you have a PSA and you don't have a prostate anymore, you know you have cancer somewhere, but there's never been in the past any good way of finding where it is. Now there are actually quite a few ways. And I found out online that there was a guy with a technique called Compodex in Holland, where they can find cancer in lymph nodes. So I actually emailed him. He emailed me back and said, well, before you come here, maybe you ought to get an MP MRI, multiparametric MRI, to eliminate the possibility of local recurrence. Okay, that sounded good to me. And he said you ought to probably get one of these new F-18 bone scans, because the bone scan I had was something called TC99 or something like that. It showed nothing in my bones, but it's not very good. It's not a very good bone scan. So I went to the Navy. I'm retired Air Force. I went to the Naval Hospital. I talked to an oncologist. I said, I'd like one of those MP MRIs. He said, MP MRIs. I think we use that in some kinds of cancer, but I've never heard of it used in prostate cancer. I said, oh, that's not very useful. How about this F-18 bone scan? Yeah, we don't do those. We use the TC99 bone scans, which turned out not to be very good. Well, I wasn't having much success there, so I'd learned from this cancer forum that there was a guy up in Marina Del Rey, Dr. Mark Scholes, who is a prostate oncologist. I said, maybe I ought to go see somebody who actually studies prostates specifically, not just a general oncologist. So I went up there, and he did recommend to get an MP MRI, and he did another test. And so I've had several tests now that seem to indicate it's in the prostate bed, nowhere else. And now I have to decide whether I want to irradiate that area, maybe get a biopsy of that particular area to see if that's really where the cancer is, and then get it treated. I could be watchful waiting on this because it's a very slow growing, 15-month doubling time. If you have a 3 or 4 month doubling time, that's very active cancer, and most of these new techniques can see it. But they couldn't see mine. So that's it for me.
You want to we'll open up to this 2 or 3 questions. You can check with him personally a little bit later, but go ahead.
I'm also retired Air Force.
Oh, okay.
I just had surgery September 11th at Balboa Hospital, board certified Dr. Stroop. How many PSAs? I just did my second this morning. My first one was 0.1. He told me 2 years before he could say you're cancer free. So is that an accurate number?
My PSA stayed at essentially 0 for 5 years. Okay, and then it came back. Now, my cancer was obviously, remember those 3 microscopic cancers I had? Well, they must have had one in the little bit of prostate tissue that was left. Even though I had clean margins, that microscopic one started growing, and now I've got some other cancer that's non-negative. So I would say I would do it at least every 6 months for the indefinite future. Once you get to 10 or 12 years, maybe you can pretty well say you're never going to have a recurrence. But mine happened after 5 or 7.
Question? Sorry, you say you have a slow growing recurrence.
That's correct, a slow-growing recurrence.
As I recall, your pre-biopsy diagnosis was severe. I mean, is that right? That seems unusual. In other words, if you had a bad diagnosis, that if you had a lot of cores, you had an 8 or a 9 or something like that, and you had a recurrence, I would expect the recurrence to mimic somehow, but that's not the case.
Right, and even though they said there was likely in my, what do they call it, the examination of my prostate after the surgery, they said there was likely lymphatic invasion. I didn't read that at the time. I thought I was just happy that I had negative margins. But when they said that I had probable lymphatic invasion, so I assumed that when I got a recurrence that it was probably in lymph somewhere. And that's why I was interested in that study in Holland. But every indication is it's local recurrence, and that has nothing to do with any of the cancers that were found in my surgery. So, I mean, I was a Gleason 7 with a little bit of level 5 cancer in one of those cancers. So I had could have been an 8 or a 9 in that little piece, but it didn't take. Maybe it was that immunotherapy I got that actually nipped that in the bud. I don't know.
Regarding the multi-parameter MRI that you just mentioned?
Yes.
Okay. How different is that, compared to, Dr. Lowe, at shops? He does, what do you call the DOE, with the DOE? He does, the MRI for prostate.
Right.
To see, if you have cancer. That is DOE by Dr. Lowe at shop. How different is that compared to the one that you did, the multi-parameter recommended by Dr. Schultz?
I'll speak to that just a little bit. It's a DCE MRI is the proper name of it by Dr. Lowe. And he is so adept at the way he's doing it, it is quite comparable to an multiparametric MRI. But a multiparametric MRI covers more area than his, meaning other parts of your body that he might find something, is the basic difference, but it's an awfully good test.
I would like to add that...
One more item, excuse me, that he's using a 1.5 Tesla machine, and most of the multiparametrics are a 3.0, which is usually a better definition, but he's getting awfully good results by the computer additives he's doing.
Dr. Schultz had a whole list of centers that do multiparametric MRIs, and one of them was UCSD. So I had scheduled a time to do that at UCSD, but just the day before I was there, I was in Washington, D.C. for a drug study at NIH, and they did a multiparametric MRI there using an interrectal coil. I thought that was at the UCSD, they don't use an interrectal coil because the people don't like them. And they say they don't have any problem seeing the same things. Well, the MP-MRI I did at UCSD was negative. They saw nothing. The MP-MRI I had at NIH showed 3 different areas of concern. And so I'm not sure I'd go back to UCSD for my MRI for my slow-growing cancer. I think I would go somewhere else.
All right, let's move on to another one here, and you can certainly, when we break the group up, have private conversations with him if you'd like. So you're up, Ron.
Okay.
Ron Abbott.
Thanks, Gene. My name's Ron Abbott. That's with 2 T's, actually. Gene. 62.
George is an engineer. What do you expect?
Okay. 3 days ago was my 6-year anniversary of being diagnosed. And see, next month will be my 6-year anniversary of participating in this group. And it's made quite a difference in my life. A little outline here. I'm going to try to follow it some. I know a lot of people have been following my case because I've spoken before and talked to a lot of people. And I thought this was a good time to give you an update. And it's a good update. The headline is, I'm not going to hide the lead here. After 20 months of ADT I've been on, I got off late last year, and my testosterone started rising again. And for the last couple of months, my testosterone has been in the 450 to 500 level. And my PSA is still undetectable with an ultrasensitive PSA test. That's less than 0.015 nanograms per milliliter. If anybody's interested in how to get an ultrasensitive test, I'm a Kaiser Permanente member, and they don't give ultrasensitive tests, and so I just get on the internet to Persona Labs and order it. It costs about $59 is what I pay. And I feel it's very important if you have had surgery or any therapy where your PSA is undetectable with a standard 0.1 to to get the ultrasensitive PSA test. When my testosterone was rising, I went from 50 to 450 in a 5-week time. It felt like kind of like I was going through puberty in high speed. But the best thing is that I'm undetectable now, and with my girlfriend, we say my superpower is that I'm undetectable. And sometimes she tells her friends that my boyfriend is undetectable. And you can imagine what people think. You don't really have a boyfriend, do you? But briefly, to go through my case, get backwards to the beginning when I was diagnosed 6 years ago, my PSA was about 9.5, and the biopsy was like 5 cores positive, 3+4 Gleason. Many of the cores were high volume, 70%, 90%. So I knew I needed definitive treatment. And in 2 months' time, I chose to get surgery. As a Kaiser Permanente patient, I had surgery with Dr. Schwann, robotic surgery, and that went well. But 10 months later, my PSA became detectable. And so normally they say your PSA needs to get up to 0.2 before they declare that you're really recurrent. And so it took about 10 months before it got up to 0.2. And then started the war of trying to figure out what to do against this new enemy, recurrent prostate cancer. And it's been an amazing effort. I've seen, there were 6 different doctors, including going up to prostate oncology specialist in Marina Del Rey, Dr. Lamb, and all of them recommended salvage radiation. And I'm an engineer. I said, no, this doesn't make any sense to me. This is an enemy. I want to know where it is. I want to have a target. I'm not going to just carpet bomb my prostate bed and hope that it's there. It doesn't make sense. So I got on Avodart for a while, and thinking that would slow it down. No, my cancers vary a lot. There's a lot of different kinds, but mine had no response to the Avodart at all. Look at my PSA chart, it's just rising rapidly. It was accelerating. You can't even tell I went on Avodart, even though my dihydrotestosterone was very low. And when I went to the PCRI conference in LA and spoke with Dr. Snuffy Myers about it, he said, well, that's not a good sign. And it comes back to that Gleason 5 cancer. I'm thinking, oh, this is pretty aggressive stuff. So when my PSA was rising fairly rapidly with recurrence, I finally, when it got up about 1, I think, I said, oh, I've really got to do something. I can't just wait anymore. The doubling time got down to as low as 3 to 4 months. And started some intensive effort, and Gene was very helpful getting some DVDs for me from the PCRI conference where they had presented about the carbon-11 acetate and carbon-11 choline PET CTs. And I said, okay, this is a way for me to find a target. And Dr. Almeida's clinical trial in Phoenix was not we weren't aware of it very much. But somehow I found him. I think it was a sequence of talking with a bunch of different people. And 3 years ago, January of 2012, January of 2012, that I got my first carbon-11 acetate PET CT with Dr. Almeida. And that he pointed at the screen after the test. They said, sit you down in front of the computer, and he goes over the results immediately. And he said, that's a hot lymph node. and immediately told me that if I had followed the recommendations of 6 different doctors to get that salvage radiation, it would have been of no benefit to me at all. And I felt, all right, I was right. And then I realized, hell, he just told me I've got metastatic cancer in my lymph system. So I was very mixed feelings at the moment. But at least I had a target, and that's what I wanted. And so I went to Dr. Munt at UCSD. I had this all lined up. It's scheduled an appointment, and he said, "Oh, slow down a little bit." He took it to the tumor board, the combined Kaiser Permanente and UCSD tumor board, and they recommended radiating the entire prostate bed and the suspicious lymph node and the entire lymph node chain. And I said, no, I don't want that. I want to minimize the collateral damage to me. I'd like to live another 30 years. I have a very active lifestyle. A lot of you know I often come here in bicycle shorts and helmet, and I haven't owned a car for over 20 years now. I decided I needed to do some kind of combined therapy, not just radiation therapy. And so I got on Casodex and Proscar just to slow it down. And that worked fairly well for about 8 months or so, and then it started accelerating again. It just kind of suppressed the advancement for a while. Didn't really drop the PSA low. But after 10 months, it was clearly obvious it was not controlling it anymore. And so I went back to Dr. Munt, and he said, well, it's been over a year since my last carbon-11 PET CT scan, and I need to go get another one. So I went back to Dr. Almeida, and the new scan found just the same lymph node, but a little bit larger. It had grown about 25%. And so I had that new information, and also I had chosen to go on ADT before and after the radiation therapy, and I'd done a lot of research and thought that the new Firmagon drug was the better drug for me to use than Lupron. Casodex was not controlling my cancer anymore, and that's often used as a precursor to Lupron. I needed to get it under control quickly after so I wanted to get the Firmagon injection immediately after my second PET CT scan. And Kaiser Permanente, I was working with an oncologist there, she kept saying, no, that's not for you. And I wrote a manifesto about why my case deserved Firmagon. And I went off to Phoenix, having sent that manifesto to my oncologist. And I was actually trying to find somebody in Phoenix to give me my first Firmagon injection when I checked my email, and she sent me an email saying, come back to San Diego and we'll start you on Firmagon. So I'm actually happy that Kaiser Permanente came through for me on this. Because the Firmagon, after just a couple of weeks on Firmagon, the testosterone drops really fast on Firmagon. Just a couple of days, it was down to undetectable. But then in a couple of weeks, I got a PSA test, and it went from 3 down to, it was a 60% drop, whatever that was. And then for a couple of months, it didn't change at all. I go, oh no, here we go again. My cancer is special. It's not responding well to treatment. And then it started dropping slowly, about 25% per month. My oncologist at Kaiser said, be patient, be patient. It may be working for you. And after a few months of 25% drops, I decided, okay, it's working adequately, and I want to pull the trigger on radiation, and went back to Dr. Munt. And this was late in 2013. Yeah. That I wanted to get the radiation therapy. So at that time, I was able to talk Dr. Mutt into radiating just the lymph node and a little bit of margin around it, a small volume, minimizing the collateral damage. And this was partly because Dr. Mutt had developed a relationship with Dr. Almeida. He's spoken here, Dr. Almeida's spoken here, and he got to know the research, and Dr. Almeida suggested the combination treatment and that maybe just treating the lymph node would work for me. So, okay, we created the plan, and I decided, let me make sure. I don't trust the medical system. I don't trust doctors. And the day before I was to start my radiation therapy, I asked to see my plan, sit down in front of the computer with the dosimetrist and Dr. Mutt and see the plan. And I went out of there scratching my head. This doesn't seem right. And shortly I decided I'm going to cancel the beginning of my radiation therapy the next day it was scheduled for. And then I made an appointment with Dr. Mutt. Got in to see him pretty quick, and he realized that there was a mistake. They had designed a plan for me that was going to treat over 10 times the volume of my body that I wanted. They had designed a plan to treat the entire obturator lymph node chain, not just the region of the one lymph node. And that's pretty much a standard of care. And Dr. Mutt told me, well, when we talk about treating a lymph node, we mean treating the entire lymph node chain, not just the one lymph node. But that's not what I understood. And I don't know exactly where the error happened, but anyway, they had to scrap the plan entirely, start over. It took another week to create a new plan, started my radiation therapy. So that was November and December of 2013 that I got rapid arc, focal radiation to just the one lymph node. The obturator lymph node is kind of in the core of the body, outside the region of the prostate bed, but fairly close by, and not amenable to surgery. At the tumor board, all the surgeons said too much morbidity, which means too high a risk. So the radiation therapy made sense for me, and combining it with the androgen deprivation therapy, quite a few experts say that they help each other, that you get better results. And one of the reasons that I wanted to use androgen deprivation therapy is also I didn't know for sure that it's only in that lymph node. There's a very good chance that it's someplace else too. And so I didn't want that someplace else growing while I'm treating that one mother load of cancer. So about 5 weeks after the radiation therapy, I got my first PSA, and I went and got the ultrasensitive PSA. Immediately, it was undetectable. It went from 0.5 before the radiation therapy to less than 0.015. And that's the most ideal response you can get from radiation therapy, is to get a really rapid drop like that. But it was with the androgen deprivation therapy. And then I stuck with the ADT until it was August was the last injection last year. And it took a few months for my testosterone to start rising again. And then the result that I told you earlier, it's still undetectable. So I'm pretty pleased with that. Early on, when I was diagnosed, I forgot to cover this, I felt I'd really screwed up. I was a basket case when I was first diagnosed, and support groups really helped me a lot. And I feel very grateful for this group and the PCREF that Dr. Barkin runs, and Richard Moyer. I don't know if you're here, Richard. Very helpful to me. And the Kaiser Permanente support group also, all the different components. I was single and unattached, and no family here in San Diego at all at the time that I was diagnosed. And so that put an extra stress on me. And the support groups were my family, and it was of great help to me. So Gene, Lyle, George, everybody, I really appreciate what you've done for me and getting me to the point that I am today. I know I might be back here in a few months or a few years saying, help, it's back.
The good point is you'll be back. Okay.
And it's not all good news, though, because I haven't had intercourse for 6 years. I'm wearing a pad still, but I'm working out at the Y, and I'm happy. And I've actually been happy for about the last 4 years. I really had to work a lot on my mental attitude to get past that being a basket case, past the anxiety and stress and depression and all. So now the simple pleasures in life, I feel joy and pleasure, happiness that I've never felt before. And so there is some gift for having cancer. It causes you to reevaluate things and change. If you got cancer, you probably need to change something. And I've changed a lot. And like one of the recommendations from this group was that when you're on ADT, go work out, weight training, because if you don't, you're really going to have a lot more side effects and go downhill and all. And so I did that, and that was really helpful. Then about 3 years ago, because I was happy and confident and all, I was able to connect with a new girlfriend. And we've had a very good relationship for the last few years. So if you're anxious and stressed or depressed about your situation, anybody out here that's single and unattached, it's possible to find love again. And even though I thought, how am I going to find somebody new with metastatic cancer and erectile dysfunction? But it happened just because I was happy and confident, and it happened naturally and easy. It's been a nice romantic relationship, supportive and all. But one thing that really surprises me, it's amazing that after 6 years, I achieved this result of undetectable PSA. I was playing whack-a-mole, and I feel I really whacked the big mole. There might be some little ones in there somewhere, but man, this is what I was hoping to have, and it's looking good right now. Also, what I have is oligometastatic prostate cancer, which means few metastases. And if anybody has recurrence, or even if you're on ADT, you still should consider that you might have the potential of a cure. Watch the video from Dr. Kwan at the 2014 PCR conference. There's a great presentation by him about oligometastatic disease and some amazing cases of success stories. Also, Dr. Myers, I think, has quite a bit of information about that. So to conclude, I want to read something I wrote here. I wake up in the morning with a smile on my face, eager to experience or accomplish something new. I have been for a few years, even while in the midst of fighting a tough enemy. Connecting with Hannah 3 years ago and making her an important part of my life was easy and natural with the new me. So if you are angry, anxious, or depressed now over your situation, accept that it's a normal part of the process. Focus on and be grateful for the good things in your life. Have courage, and you can create a new you with love, peace, happiness, pleasure, as joy as a normal part of your life. Thank you.
Okay. Any specific questions? Good job, Ron. Any specific questions of Ron? A couple?
How old are you, Ron?
I'm 62.
52?
62. I was 56 when I was diagnosed.
Are you undergoing ADT now or any of the?
No, I'm not on any treatment at all
When
now.
did that stop?
The last injection was in August, and with Firmagon, yeah, last year. With Firmagon, it's a monthly or every 4 weeks injection, actually. But still, it took a few months before my PSA was up to like 50, and then it jumped from 50 to 487 in 5 weeks.
Testosterone, not PSA.
Yeah, the testosterone, yeah, not the PSA, testosterone.
Ron, how much radiation did you get?
It was 56 gray, 28 treatments. So it's a smaller amount of radiation than if I had done the prostate bed.
That's an awful lot for
Yeah, it seems like a lot for one little lymph node. It was a 14 cc treatment volume, and the original plan was for like 150 cc treatment volume. And Dr. Munt, I just recently informed him of the results with my low PSA while testosterone is high, and he said, "You made my day." He was really happy to see the good result.
One more here. Ron,
Yeah.
Firmagon, is that equivalent to Lupron?
It's similar to Lupron, except for it activates, it suppresses a pathway immediately, whereas Lupron overstimulates a certain pathway which causes an eventual shutdown of testosterone production. So there's a flare of testosterone in the beginning with Lupron, and there is no flare with Firmagon. Also, Firmagon is supposed to be better in that it retains the value for a longer period of time. It may hold certain hormones down for a longer period of time.
Okay, just a comment for the audience. I'm on Lupron, and my doctor talked me into changing to Trelstar instead of Lupron for a 1 3-month period. And in that 1 3-month period, I had significant increase in PSA. Tremendous. Increase, 6 times. Yeah. Multiple 6 as opposed to my PSA had been doubling. And I think the reason why the suggestion was made to go to Trelstar was cost. And I immediately went back on Lupron. And it's slowed it down some. So for what it's worth, I don't think Trelstar is worth a damn. And some people it does work. That's one of the unfortunate things. Sometimes it is trial and error. So, okay.
Quick question.
Okay, go
How do
ahead.
you spell Firmagon?
Firmon. Just think the firm is gone, which is, I don't know why they named it that, but it
I never thought of it that way, Ron. Only you would think that. Okay. All right. Let's move on. And the third speaker called me 8 o'clock last night and said, sorry, I can't make it. So I have a better alternative, and Bill Manning offered to step in because I like to. Some of this can be very confusing to you people that are here for the first time and don't understand terms and so forth, and can be a little bit frightened. My gosh, what are you guys going through and so forth? There is a better way, and I'll let Bill Manning, if you got yourself focused.
Yeah.
Okay. Let him pick up and talk about active surveillance, which he's been on now for a number of years. He did all the right things in the beginning.
Thank you, Gene. Okay, so in the middle of 2009, I applied for some extra life insurance, which required a PSA, and it came back 4.1. Well, it seems that I passed the magic number. Had it been 3.9, I would have been just fine. But 4.1, I'm sorry, but can't help you. You know, you're hopeless. So I figured I'd show them, and I'd go to Kaiser and have a retest, which I did. And funny thing happened on the way to the lab. I got a 6. So I went, oh, okay. Well, I didn't know at that time exactly what that meant. However, my urologist was more than happy to fill me in that the next step was a biopsy. So I got put on the prostate cancer conveyor belt and went in for my biopsy, came out, and of course they had bad news. You have cancer. And my question was, well, how much and how bad? Well, out of 12 samples, one had a little bit in there. So, what would you like to do, surgery or radiation? And I said, let me think about it. I told my wife this, which of course at that time she went bananas. And I said that I would like to do some research into this. And her opinion was that you don't research cancer, you treat it. And I felt that I needed to know more than I was being told at that time. To Kaiser's credit, they did have a program that it gave you a little bit more information about what was going on. You got a private one-on-one meeting, and then I went to their support group meetings. In fact, I met Ron there. And it was informative to a point. And that time, Ron suggested that I come see this other support group that was meeting up in La Jolla. You never guess which one that was. So I went to my first meeting here. Well, actually, we were at UCSD at that time. This is 2009, and September. And I learned an incredible amount at that time. And probably the biggest thing I learned was to put on the brakes and not go plummeting off the cliff just because my urologist had a set protocol on what you have to do or should do. I was obviously a low-risk individual. However, that didn't stop the conveyor belt from moving, which basically was, well, surgery, radiation. Let's flip a coin. So I met with the surgeon, who was more than anxious to get me on the table. Oh, you're a good candidate. Of course I was. I was healthy, I was relatively young. Chances of things going wrong were small. Of course I was a good candidate. But in the meantime, I was learning more and more and more, and my urologist did kind of say, yeah, surgery, radiation, or watchful waiting. So, well, what's this watchful waiting? So I looked into that, and then I also picked up a book called The China Study, and I read The China Study. And after going through all of this and meeting with the surgeon, I passed on meeting with the radiologist because I pretty much knew at that point I was not going to do what they suggested, that it was a time to go on to active surveillance. Now, that didn't mean just simply ignoring everything, because what I learned here is that you needed multiple tools in your toolbox. And so, at that point, I went to Ventura and met with Dr. Duke Bond, who does a process called colored Doppler ultrasound. And he did an ultrasound on me. And this is for those that are not familiar with it, this is a completely different form of ultrasound than what the urologist does when he gives you your random biopsy. And that I should also mention is a key word here, random biopsy. Remember, we've got 12 samples being, randomly taken from the prostate, and Dr. Bond doesn't believe in that. He believes in what are called targeted biopsies. Well, at any rate, so he did the ultrasound. He said, well, yeah, there's some screwed up cells in there, but I don't think this is really clinically significant. I think you're okay just putting on the brakes and come back in 6 months and let's check it again. We now have a baseline. Went back 6 months later, basically the same thing again. Well, things look a little screwy in there, but you don't have any tumors, and I think that you'll be good. Just PSAs twice a year, make sure you get a DRE, and come back and see me in a year. So, PSAs, DRE, Bond in a year. Got it again. And everything seemed just about the same. Now, I might mention that after that peak, when my PSA went up to 6, I guess you could almost call this a story of a tale of two peaks. The first peak was way back when at 6. Well, it went back down. It dropped back down into the high 4s at that time. And over the years, it's done kind of a bouncing ball, going back and forth. And meanwhile, my urologist, as time is going on, suggested I have a biopsy annually. And I asked why. He said, well, because. And I said, well, okay, I'm missing the logic here. So if my PSA was steadily rising each time it was taken, then perhaps that might make some sense. But if my PSA is going down and then maybe it goes up a little and then it goes down again, wouldn't that suggest the opposite, that I wouldn't need one? Well, you know, we just want to be safe. I might mention he has since retired. So my new urologist, looking at all this 3 years into this, said, well, you know, whatever you're doing seems to be working. I mean, your PSA is stable and it's staying in a good range and not doing anything weird, and I think that's just fine. So in 2013, I went and saw Dr. Bond again, and he wanted me to do a biopsy, which I was reluctant to do. And I said, well, I'll do it if you give me some compelling evidence as to why I need it. Well, after doing the ultrasound, he furnished me with what he felt was compelling evidence, and that was that something had changed. There was something different on my ultrasound than all the previous ones, and it looked suspicious to him. Nothing glaring, no A-bombs, but it looked suspicious. So in that realm, I said, okay, fine, go ahead. And he did a targeted biopsy, 7 cores, in the exact area where he was concerned that there might be some growth. So they took those samples, did the pathology up at Ventura. I got a call from him the following day, and he said, well, guess what? I'm going, what? And he said, couldn't find anything. I went, well, like, oh, nothing? And he said, well, yes, like nothing. I went, well, isn't that a pleasant surprise? So, okay, just for a little test here, I decided to have those samples sent down to Kaiser and have them do a double check. Now, of course, the funny thing was when I asked Kaiser about being a second opinion here, I think they didn't know what the hell I was talking about. They literally did not understand what I was asking for, because I'm sure it's always the other way around. You know, everybody wants a second one from them. But at any rate, they agreed, and they looked over it, and they confirmed Dr. Bond's pathology that no, that was all negative. There was one sample that did have some pin in it, but it was not something to worry about particularly. So basically, starting in June of 2009 through today, I have been under active surveillance, and I am also considering doing an MP MRI this year, even though on one hand I don't have any symptoms or anything with my PSA. Oh, wait a minute, we got to go back to the tale of two peaks. So last year, my PSA, basically in the high 4s, low 5s, suddenly shot up to 7.5. Now, my old urologist would have probably strapped me on the table at that point and forced me to have a biopsy. My new urologist, on the other hand, went, well, okay, this is something, maybe we should have a PSA a little sooner than 6 months. So let's do that. No problem. So I went back, dropped from 7.5 to 6. So whatever caused it to jump at that point, we really don't know, and it doesn't matter. It's not something that requires a treatment. So my new urologist, much more forward-thinking and much more amenable to active surveillance, has gotten with the program and says, okay, see you in 6 months, DRE, PSA. But as I mentioned, I'm thinking very seriously of doing an MP MRI just for grins this year, just to add that added tool to the toolbox. And that's basically, I have to look back now on 2009 and the completely different course that this whole thing could have taken had I just simply gone along with what the first thing was that I was told. Had I not found this group, Lyle and Jean, who provided an extreme amount of support and education. And, you know, the other part of it, too, is I have to credit my wife in that even though she was freaked out in the beginning, that after several months of looking at all the different aspects of prostate cancer, and specifically where I was in this low-risk category, that it really didn't make sense to get on the conveyor belt. So she became 100% supportive at that point, and in fact, shares in a little bit of my, I don't want to call it anger, because that's not correct, but thinking back in 2009, the completely different course that things could have taken, and my story would be quite different than what I've got now. So that's basically the story of active surveillance.
Go ahead.
Has your urologist given you a benchmark number for your PSA where you may move on to a different approach?
The short answer to that is no. But you brought up a point that I really wanted to also mention, is that Dr. Bond, in measuring my prostate, see, your PSA is going to be reflective of a lot of different things, but one thing that does play a factor is the size of it. And somebody with a 40 cc and somebody with an 80, like me, is going to have completely different PSAs, and he comes up with what's called a predictive value based on how large your prostate is. And basically, my PSA should be somewhere between 8 and 9 based on its size. In other words, 8 could be perfectly normal for me, and that's where that whole business of the magic 4 really is not a, you know, it's a statistic, you know, period. But you really can't use that as a, you know, an oh my God number.
Hey, Bill. My story is pretty close to yours and also Ron's in some way. I'm also an engineer. I investigate all these things. And after having this, I was diagnosed in 2009. Probably had it in 2006. I've been on active surveillance ever since, except for a short period of time in which I did use a 6-month or 3-month period of Casodex, found out I'm certain that breast cancer, God knows what's going on, so get out of that stuff. So from now on, I went free of that, and my PSA had been a scan or something in that range like that. Now it is 6, and it's been at 6 for a year and a half. Just steady. Let's do this, I'm going to do that, I'm going to do something else, but I have another difference. I'm 83 years old, a little older than others, and with an 83-year-old situation, I have other issues. I have a carotid artery issue here that may require surgery coming up, what have you. So all I need to do is I need to keep this monitored and under control. And of course, I also use 2 urologists. I use Dr. Nigel, who's with the Genesis group, and I use the VA. And with another VA story, hey, we got some, I thought, oh, one time, there should be an oncologist in my future, because I'm probably going to look at radiation. So at that time, I was doing, imagine this name, in my urologist at the VA was Dr. Dick. Some of you may have heard Dr. Dick, he's been here. He's now on Genesis. And I told him I have a new girlfriend, like Ron. girlfriend, I would like to increase my testosterone. And having had this combination, okay, once the BA's oncology department, I went up to this guy and he said, oh, you're using testosterone, da. You're crazy. I said, whoa. I said, I got the ammunition, I got it with me. The one study that said it on a dog or some other damn thing had no meaning whatsoever. So the idea that testosterone by itself creating a problem for me, they ignored that. So that's the last time I saw that guy out the door. So I think that's a theme you hear from the guys who've been around for a while, is you get some really bad information. Occasionally you get some good information. But thanks for your
That's why you come here.
Thank you.
Okay, hold on.
Are you through, Bill?
Pardon?
Are you through?
Yeah.
Yeah. Let's take this question and then go.
You said you read, excuse me, the China study,
Yes.
and how did that change your lifestyle? Did you change your diet?
Yes. It mimics what is in the China study.
Thank you.
Which is mostly vegetarian, correct?
Completely.
Thanks very much. All right, Lyle?
Good morning. I came up here to say something special. I think everyone knows I was pretty sick last year. I was in the hospital 4 times, had 3 major surgeries. And all the time that I was running this group years and years ago, I was always worried about the continuity. And I have to thank God for Gene and everything he does for this group. Gene Van Vliet is a wonderful man, and he was recognized this year with the Harry Pinchot Award at the National Convention. So I want you to know that's a national award. It isn't just San Diego, it isn't just Iowa or someplace. It's the whole United States. So he's a good guy and he does a wonderful job for a lot of people. Thank you.
Thank you. It's a mutual admiration society. He's the first voice I heard when I was suffering my second failure and in total despair, and that's the first voice that I heard, and he said, "You're not going to die." By God, he's been right. He will ultimately be wrong, but he's keeping me going real good.